everyone. Welcome to Partner Snippets. I'm Tori Hanlon, and today's topic is Beyond Stress, Addressing Crisis During Residency. So stress management and fatigue mitigation have become prominent topics in residency training, and the ACGME has placed increasingly greater importance on these two areas by limiting work hours and requiring residency programs to adjust work schedules, educate their residents and faculty, and develop strategies to address stress and fatigue in residents. And even more recently, much research has centered on crises beyond stress during residency training, and it's even taken center stage in the news and in the press. So in this piece, we are going to look beyond stress and identify some of these issues that are greater than stress. We're going to look at why they are important, and then what programs and institutions can do to address them. So we'll examine some strategies that institutions can take to face these issues. Emotional exhaustion, burnout, depression, substance abuse, self-doubt, and even suicide. These are some of the real issues that are plaguing today's residents. Studies have shown that rates of burnout amongst interns may increase up to 55% throughout the academic year. And increased rates of burnout are associated with increased rates of depression, which have been shown to affect nearly a third of interns by the end of the academic year. The difference between stress and physician burnout is really the ability to recover during time off, and that's key. Physician burnout may include emotional exhaustion, depersonalization, and self-doubt, or even a reduced sense of accomplishment. This can lead to a reduction in quality of care, increased medical errors, and less compliant patients, which we all know is a major focus of many teaching institutions today. In addition, burned out physicians are likely to have diminished professionalism and less satisfied patients. So as medical education professionals, we have an obligation to address these issues that may affect the safety of patients and the safety of residents. The most serious end of this spectrum is suicide. Approximately 400 physicians take their own lives every year. That's a rate at more than twice the national average. Suicide accounts for 26% of deaths among physicians aged 25 to 39, as compared to 11% of deaths in the same age group in the general population. So these statistics may surprise you. Why are these issues more prevalent among physicians, including residents? So as new doctors, residency training can take a toll on residents' mental stability and physical health. There are increased work hours and workload, and greater expectations and demands placed on residents by others and themselves. And then, as even more concern, these issues frequently go unrecognized in residents. So this also includes self-recognition, residents being able to see this in themselves, as well as recognizing this in others. And there seems to be a sense of eliteness associated with physicians. So they're held to higher standards than the general population, and there's greater pressure on them to succeed. And I don't think this is by accident. Our culture has created this phenomenon, and this is why these are important issues that need to be recognized, discussed, and addressed openly. So the ACGME has revised the common program requirements to include other elements besides stress and fatigue. Residents are expected to have an understanding and know their role and responsibilities in recognizing impairment and illness in themselves and others. And it is residency programs' responsibility to ensure residents have that understanding. To be able to address some of these issues, we need to have an understanding of what causes physician burnout and may contribute to depression and suicidal thoughts. Some contributors that have been identified by residents include lack of time to exercise and take care of oneself, as well as lack of time to participate in leisure activities outside of work. Additionally, conflicting responsibilities at work, home, and with family are added stressors. Even time spent documenting in an electronic medical record has been cited by residents as a contributor to burnout. Documentation and EMRs are really just two of many ways in which the practice of medicine has changed over time and may be contributing to higher rates of physician burnout more recently. Overall, the current practice of medicine has really created a loss of autonomy for physicians. The physician is limited in his or her ability to decide when to see a patient, how much time to spend with a patient, when to see them next, what tests to perform, and even what treatments to try. These types of decisions are no longer solely the physician's to make. Reimbursement policies, increased guidelines, and technological advances, while perhaps mostly positive advancements, have really contributed to a decrease in physician autonomy, which is a contributing factor to burnout. Other contributors to consider: physicians have a high level of responsibility with oftentimes little control over the outcome, and they're working with ill people all day long. So patient encounters can be challenging, complex, and emotional, and it really can be draining day in and day out. Residency is not easy, and as you can see at the picture on the screen, I think we all have been in a place where we feel we're being pulled and tugged in different directions, and you can see this physician on the screen has so much going on and so much that he's thinking about. So I think this is a very relatable picture, not just for physicians, but for all of us. And as programs, we are constrained to a certain extent in order to uphold educational requirements and board eligibility requirements. So we're not as free to be able to do maybe what we want to do all of the time. But we can evaluate methods to help residents cope and even to steer them towards engagement and not physician burnout. So we're going to take a look at what institutions and programs can do to tackle these issues and mitigate the effects on the quality of health care that's delivered by residents. First and foremost, we need to start talking about these issues with residents, with faculty, and within the larger GME community. Anyone who attended the recent ACGME conference knows that this was a theme throughout the conference. And really the conference started with Dr. Nasca addressing resident well-being during his CEO address. We all need to be comfortable talking about and addressing these issues, and we want to eliminate the perception that asking for help may be a sign of weakness. So when we begin discussing these subjects candidly, hopefully more residents will feel comfortable expressing any doubts and fears that may be contributing to feelings of inadequacy and depression. Programs can even expand upon their current education and discussions around fatigue and stress to include these more serious topics. And I think that's important because programs and institutions, I think at this point, really have the fatigue management and mitigation part down. So it's time to start looking beyond fatigue and stress and really bring some of these more serious topics into conversations with residents to know that it's not just fatigue and stress that we're concerned about and looking at because it's written in ACGME requirements. Programs and institutions can utilize resident forums and group meetings as a place to begin these discussions. We all have resident forums in place now, and I think we're starting to add more and more. Quality improvement is a good example, and resident well-being, I think, is an excellent topic in order to form a resident forum around. Forums and meetings may not be the place for individual personal discussions, but certainly discussions of these topics in general, including identification of the issues and resources to turn for help. I think you'll find that some residents do have a passion for this and want to be involved in making resident life easier and better. I certainly would encourage the use of a faculty member who can facilitate a discussion on these topics, or even someone from the outside of the organization who has no ties to the residents. So as an example, an institution I used to work for worked with a psychologist who, in addition to leading discussions on burnout, worked with all of the residents, actually observing them in the patient care setting. So this psychologist was able to provide insight and evaluate the residents on behavioral measures that may not be addressed by other faculty members through our traditional resident evaluation process. So having someone professionally trained in behavioral medicine really proved invaluable for that program in the early identification of resident issues, including burnout and depression. I definitely recommend instituting a regular monitoring program for physician burnout amongst residents. You can incorporate this into resident self-evaluations if you do them. You may also want to think about having conversations with residents during their semi-annual evaluation face-to-face meetings. This at least opens the door for residents to communicate any personal issues in a safe and private environment. Something else to consider is the establishment of a forum or support group for residents' families. A lot of bigger institutions have something like this in place, resident auxiliaries. Oftentimes it's led or co-led by a spouse or a family member of a resident, and helping significant others and families of residents and getting them involved in this type of thing. They have a better understanding of the rigors that are involved with residency training and how they can contribute to a stronger support system at home. Having this stronger support system at home can help to mitigate resident stress, which of course can lead to some of these more serious issues. This type of group or a resident auxiliary can also act as a social outlet for residents and families to form bonds with each other who are also experiencing the same things. And I think that really is the main point from the resident auxiliaries that I've seen, is it really is more of a social outlet. But it does bring people together, and it brings them together outside of work. And so they're not thinking about what's going on or some of the stressors associated with work. So that's a really good thing. And then one creative approach to consider in managing resident stress and preventing burnout is to incorporate some kind of leadership training into resident orientation and even throughout residency training, and not just for chief residents, but for all residents. And so you're probably thinking, what does leadership training have to do with stress and physician burnout? But think about it. Residents wake up one day into a position as a leader of the healthcare delivery team without really receiving any kind of leadership skills training, or very little training at best. So this can contribute to additional stress and added pressure to an already overwhelmed resident. By providing some formal leadership skills training and education, residency programs and institutions can provide the necessary support and resources for residents to be able to succeed as providers and leaders in today's healthcare environment. One place where I would certainly go to first regarding leadership training is your own maybe corporate education departments at your institutions, or possibly this comes out of HR. I know where I work, they have some formal leadership skills training and classes for managers, directors at the institution, and we were able to take bits and pieces of those programs and create one specific for residents. And I think it's also important to periodically remind residents why they became doctors. Really getting back in touch with their personal motivation to be a physician can be very powerful. Reconnecting with their purpose may be able to provide the momentum needed to mitigate burnout. Also, some simple strategies, even to recognize residents and make them feel appreciated, can help to promote resident well-being and create a positive work environment. I think we all can relate to this in our own work environment. It's always nice when we feel that somebody tells us that we're doing a good job. So this may not be something that's going to address some of the more serious issues, but it is something institutions can do to help mitigate burnout and really contribute to that resident wellness. Things such as establishing a resident recognition award, maybe on a quarterly basis, or even just recognizing resident accomplishments publicly are both ways to more formally appreciate residents. And then don't forget to tap into your organization's resources that are already in place, such as the Employee Assistance Program and even employing wellness coaches and stress management classes. It's really to your benefit to utilize such organizational resources. They're right at your disposal. So if you haven't done so already, certainly reach out to your HR department or corporate education department to see what exists at your organization. Like I said, we had reached out to those two departments specifically about the leadership training, and that worked out very well for us and our residents. And then just as important as employing any of the strategies, it's really creating that awareness and educating faculty on all of these important topics. So faculty should have an understanding for their own sake as well as for their role as resident mentors and educators. So this is certainly a good topic for a faculty development piece. Faculty need to be able to recognize signs of burnout, exhaustion, depression. Our goal, in addition to mitigating effects of these things, is to be able to recognize physician burnout in the early stages before it progresses into something more serious. So my goal for this piece, and an important takeaway, I hope, is the creation of awareness of the issues. I think that's definitely the first step. I do see this happening in the media as well as GME networking circles. Clearly, the ACGME conference, this was a trend. This is definitely a positive sign. As awareness grows, so will additional innovative strategies to tackle these issues, and we will all learn from each other. I hope you can take some of these strategies with you and employ them and even build upon them in your own organizations. Please continue to talk with others in GME, both in your organization, outside your organization, and by doing so, I hope we'll see a decline in some of the surprising statistics that was presented at the beginning. So let's shift the focus from being a reactive one to a proactive one focused on resident wellness. Thank you for joining us on this snippet. Look for more partner snippets in the future.